move to the first speaker. And Michael Gibson from Vanderbilt University, a guy I've also known for a long time because I went to college with his wife. Mike was across town at NC State. There was a basketball game last week that I think Mike's trying to forget between UNC and State, but I told him I wouldn't mention it, so I've not mentioned it this morning. Mike has just been at Vanderbilt 2 or 3 months. He's going to talk to us about immunotherapy and recurrent disease. Thanks, Mike.
Go Tar Heels. What Bob failed to mention is that he already carried out the fireman's carry with me. That's how he practices. Good Saturday morning to everybody. It's Saturday. This is good. The weekend has started. As I've reflected on the meeting, I realized that I learned a great deal as a medical oncologist from the multidisciplinary nature of the meeting. In addition, I realized that most of what is in my talk has already been said. So I retooled my talk a little bit and added a bit of a sort of a timeline feature to it with the goal of putting this incredible advance of immunotherapy into the context of the many, or maybe not so many, slow advances that had occurred over the decades before that. Disclosures has already been laid out by Dr. Ferris, Dr. Nathan. Learning objectives. So I'd like to review, I won't spend a lot of time on it, but to review the history of the treatment for recurrent metastatic head and neck cancer. Then review immunotherapy treatments, the ones that are FDA approved. There's 2. Then go over ongoing trials and the future, including, I think, the type of excellent work that Dr. Mendez was planning and that Dr. Burtness will continue in his honor. The history of treatment for recurrent metastatic head and neck cancer sort of fits into this timeline. I wanted to point out with my college in surgery that surgery always comes first, including on this slide, followed, of course, by radiation therapy, which is the sponsor of the meeting, ASTRO. And then really shortly after I was born, chemotherapy came into the fold for recurrent and metastatic disease, and then followed very recently biologic therapy. And you can see from the vertical, I guess, timeline of chemotherapy, as mentioned, starting in the 60s, methotrexate was the beginning. And in fact, if you look at the Keynote 040 and the Checkmate 141 trial, it remains a treatment for recurrent metastatic disease. We developed fluoropyrimidines, carboplatin, cisplatin, and then in the 90s, the taxanes were developed and studied widely as sort of the new generation of cytotoxic therapies. Unfortunately, I don't know if the best is not the right word, but the conclusion, I suppose, of studying cytotoxic therapies up into the taxanes is shown in the results of E1395, and what you can see in a very disappointing manner is that the curves overlap. So the trial was started, I guess, in the era when taxanes, if I recall, they were the most recently FDA-approved therapy at the time. And even when you combine those with a prior very active platinum regimen, you saw no improvement in outcome. Fortunately, 10 years later, after the taxanes, we got this. Cetuximab is an immunotherapy. Dr. Ferris taught me that, among many other things. But I should add that this was a breakthrough, right? So this came along at the time of the original antibody-type therapies. Others would be angiogenesis inhibitors like bevacizumab. And when you combined in the EXTREME trial, which was a randomized study with a large number of patients with whom the gold standard outcome survival was the endpoint. The before-mentioned platinum fluoropyrimidine combination was compared to the same plus cetuximab, and this is the outcome, which you all know. So that was a huge leap forward. The disappointing part is it took 10 years to achieve this after the taxanes were first on the horizon. But it was a big benefit, and as you'll see in the ongoing trials with immunotherapy versus standard of care, extreme is the standard of care in those studies. So, 10 more years later, another decade roughly, finally, immunotherapy with checkpoint inhibitors arrives in the clinic. And these drugs, and I put very simplified because this is for me, I didn't mean that for the audience, is a very condensed version of what Dr. Ballman so eloquently broke down in great detail in her plenary session, which is sort of the immunologic tumor cycle, I think it's called. So there's 3 components, right? And that's actually how I break down the mechanism of the immunotherapies that we'll describe later. There's the point where antigen-presenting cells vacuum up. We can call them neoantigens, and that can be that's in the tumor microenvironment and can actually be augmented by things like toll-like receptor targeted therapies. Then the antigen-presenting cell leaves the tumor microenvironment and goes to a draining lymph node, which is sort of the center of this cartoon, interacts with T cells, which recognize the neoantigen as a foreign entity, and they're activated, and then go back to a very complicated area, the tumor microenvironment, to carry out their job. The job, if you're the patient, it's a good job, is to eliminate cancer cells. But of course, the immune system has many checks and balances. If it's overactivated, you get trouble with autoimmune problems, which also are side effects of these checkpoint inhibitors. So there are checkpoints. And on, let's see, the right side of the slide, to me, there are the orange parts of the cartoon. One of the ways, again, I said this is very simplified, that the tumor cell can co-opt the host immune process is to make ligands to something called the programmed death receptor, and that is a check on the activated T cell's ability to kill the tumor cell. Very smart people created drugs. We'll talk about the details. One is actually there's 2, so I'll hold off on that. But what happens is these antibodies are able to bind to the ligands and check the checkpoint. And I like to think that 2 negatives make a positive, and a positive in this case is the ability for the T cell to activate and kill tumor cells. So the bottom line of this immunotherapy for head and neck cancer and any other cancer is to figure out ways to exploit any component of this mechanism, antigen presentation, T cell activation, inhibition of checkpoints, so that the host immune system can recognize the tumor as foreign. So moving into the current environment, there's 2 drugs, which I couldn't remember a minute ago, nivolumab and pembrolizumab. And I'm going to repeat this slide. I'm just going to change the name of the drug at the top. So both of these agents are anti-ligand monoclonal antibodies that suppress this checkpoint, and another even more simple mechanism is shown here. Nivolumab was studied in many phase 1 and phase 2 trials in multiple diseases, but the study that is the definitive work, and this is, I think it's shared with Dr. Gillison and Dr. Ferris, among others, is Checkmate 141. This is in a second line, or I guess more technically speaking, it's platinum-exposed patients. So these are patients who have persistent or actually recurrent as well disease after getting a first-line regimen, like Extreme, for example. Doesn't have to be, it just has to have a platinum. And these patients were randomized in a 2-to-1 ratio to single-agent nivolumab, or, here comes methotrexate, Investigator's choice, methotrexate, docetaxel, there's the taxane we talked about, or cetuximab. And the primary outcome here was overall survival, which is shown here. If you compare that historically, obviously, to the EXTREME trial, curves are also separated. The outcome is a little better than adding cetuximab to cytotoxic chemotherapy. And in fact, the 1-year overall survival, as you already have seen multiple times, is approximately doubled compared to investigator's choice. And if you're a fan of hazard ratios, there's a 30% reduction in the risk of death for patients that are on Nivo versus standard of care. So we can give nivolumab in our clinic based on this data, and we do. Second drug which is available, pembrolizumab. I mentioned I would just switch out the name and have the same cartoon and description, so let's go straight to the data. I was able to pull earlier data for pembrolizumab. I almost said panitumumab, sorry. Pembrolizumab, because there's more of a progression in my mind of the development of this drug for a similar setting. It came out of Dr. Seiwert's study. It was a Keynote 012. It's an expansion cohort of sort of a bucket study in a similar patient population. Here's the design, but it's not randomized. There's no control arm here. So it's simply sort of a straight-on phase 2 trial in a similar patient population. Neither of them selected based on PD-1 or HPV, by the way. And the data here is to show you, more to prep me for the question about HPV, but you can see that the overall response rate, I didn't say survival, I said response rate, was in the 25% range. Perhaps it's easier to see in a waterfall plot. This is better for me to understand. So there's a lot of downgoing tumor on the right side of this plot, so very encouraging. And in fact, the drug was given a preliminary approval based on this and some other data for a similar indication as I described for nivolumab. Follow-up studies, Keynote 055 is sort of the official phase 2 trial, not a run-on from a phase 1 multi-cohort trial, which showed this. Please note again that this is a single-arm study and that survival is on the right side. The HPV is in yellow positive and in gray negative. And then Keynote 040, which was presented at ASCO, which unfortunately I didn't get to see because I wasn't in Europe, but I think this is Ezra's study, and this was really, if you were to put side to side the Checkmate 141 and the Keynote 040, you'd find very similar inclusion criteria. In fact, you see the same control arm, investigator's choice, methotrexate, docetaxel, or cetuximab. So very similar studies. What I think got me about interpreting this, but among others, is that when you look at the curves, they seem to be pretty far apart. I think in second line or recurrent metastatic head and neck cancer, if you can see space between the two curves, that's usually a good thing, especially if the experimental arm is on top, which it is. And even if you look at the hazard ratio for death, it's there's a 19% risk reduction. And in fact, at 12 months, you can see the difference in percent of patients that are alive. I think it's around 10-ish%. But based on the statistics, this is not considered a statistically significant study, although many people would argue that this is clinically very relevant because it does show similar outcomes to Checkmate 141. So I looked up the current FDA recommendations, and it says we are not changing our recommendation for pembrolizumab, and we're further evaluating the data. So that's the current standard. You can go back to clinic and give those drugs, which is a great thing, but it took 10 years to get from cetuximab to checkpoint inhibitors. So I'm hoping, as I describe in the next few minutes, the next phase of development, this will take a lot less than 10 years. There are not hundreds, probably thousands of studies going on now looking at various modulators of the host immune system at the various portions of that cycle, and you can think about how you might combine, sequence, add radiotherapy, which is an immunotherapy, for example, as well as surgery, combinations, sequences, et cetera. And talks later today will talk about those combinations. But you can see that there are plenty of, I guess, disease targets which we can look at. And, you know, across the board, these types of combinations are being studied. And I can't help but mention this before I go into head and neck specific information. And this is Luis Diaz's and Young Lee's study looking at mismatch repair deficiency and how well those patients respond to checkpoint inhibitors just because of that finding. So keep that in mind in the clinic. If you don't have something that fits perfectly, you want to check MMR and see if patients will qualify for this. But going back to head and neck cancer, the drugs I'm going to discuss focus on the tumor microenvironment, which just based on this slide looks to be pretty complicated. My understanding is that there are hundreds of challenges just in the tumor microenvironment to keeping immune therapy from working, simply such as oncotic pressure within the tumor and disorganized vasculature can interfere with delivery of drugs, to things that are more, I guess, scientifically complex, such as cytokine milieu, metabolic, activity, cellular components, TAMs, et cetera, et cetera. So if you want to make progress beyond nivolumab and pembrolizumab, you need to base your studies on questions such as this, and you need to talk to scientists and your colleagues to find out the best way to select patients, but also to combine and sequence drugs. And as time expires, I'll talk about a couple of these that are under study, and then I'll pass it on to my colleagues. So these are just a short list of drugs that are being developed and combined. So IDO inhibitors, LAG-3, TLR agonists, oncolytic viruses, angiogenesis inhibitors. Those can enable normalization of the vasculature and delivery of agents, her family member inhibition, metabolism, and more. And I got just a couple of examples from my fellow, actually, David Yao, to show you to close. So this agent, IDO indoleamine 2,3-dioxygenase, is released in the hypoxic conditions in the tumor microenvironment, and in and of itself is immunosuppressive. So we have drugs. Epacadostat is being studied in the combination of a checkpoint inhibitor to see if that will augment the effect of the checkpoint inhibitor on outcome. That's one of many. A second might be another checkpoint, which is LAG-3. Drugs against LAG-3 are widely available and also being studied in combination with anti-PD-1 treatments for various solid tumors, including this trial here. This is kind of cool, intratumoral injection of a TLR9 agonist. So this isn't a systemic delivery such as the TLR8 drug that we looked at. This is injection into the tumor, multidisciplinary, you got to get it in there. And what you do is, with this agonist, it activates many things in innate immunity, but one is to augment uptake of neoantigens in the microenvironment, so that portion of the immune axis can be modulated. One such study, pembrolizumab plus SD101, it's a KEYNOTE trial. And then finally, also kind of cool, intratumoral injection of oncolytic virus, again, a multidisciplinary approach. You have to get the virus in. This destroys cells, kind of like radiation does, releases more neoantigen, more uptake by APCs, and hopefully more activation of the host immune system. So just 4 of hundreds of thousands, probably not hundreds of thousands, but hundreds and thousands of studies looking at this. So I hope I didn't spend too much time looking at the history. I didn't want that to take that away from the immunotherapy review, but I gave you an idea of how we came from methotrexate to taxanes to cetuximab to checkpoint inhibitors as a launching pad for all the future studies. The emergence of immunotherapy has been groundbreaking. 2 drugs, Pembro and Nivo, are FDA approved. Future directions are many, so we all have a lot to work on, which is good, because this will benefit in the survival and the quality of life of our patients. Thanks.